Good morning, everyone, and welcome to the June 16th Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. We continue to be hopeful as it seems we're finally returning to some level of normalcy, and we're happy to report that caseload in Michigan continues to improve. This morning, at some point, we're going to hear from our CEO, Dave Herbal, who's going to talk a little bit about our conference coming up and a little bit about what's going on here at Leading Age Michigan. You can move the slide forward, Blake, please. And then we're going to also hear from Dalton Herbal, our Director for Public Policy. He's going to have a budget and advocacy update. And we'll finish with a review of the Michigan caseload numbers and new guidance. Mostly today we're going to be focusing on PPE, the OSHA temporary standards, and the updated MDHHS best practices document that came out yesterday.
Good morning, everyone. Thanks for joining today. I'm going to go ahead and take over this first part of the presentation. So the legislature is approaching their summer vacation period here. I think they have about a week and a half left, depending on how you count your days. And that means the last week of June, they are going to go on to summer recess and meet, I think, once or between 1 and 3 times a month for the next 2 months. Ideally, their goal with the governor and the governor's goal was to have the budget talks done by the end of this legislative period before summer break. If you recall last year's budget talks, you heard a lot of kind of political mudslinging going back and forth, saying that the legislature went out for summer break, or saying the governor didn't help us get stuff done before summer break, etc. And it looks like the same thing's going to happen again. And so this is because, as I stated on the slide here, the budget talks have, well, they've restarted and they're actually talking compared to last year. They're not going well. The governor views the Republicans' proposed budget as unrealistic and unacceptable. I did want to note, though, that the $37.5 million fund for SNF census reimbursement is not threatened through any of this. I know some members contacted me and were concerned that maybe this kind of delay may threaten this fund. It's not threatened in any way. The governor was the one who proposed it, and the legislature, between the House and the Senate, both like this fund being in existence. The real debate is that the direct care worker funds are still kind of being figured out what they want to do here, and then there's a number of other things they're trying to figure out. Now, 2 days ago, I know this is workforce is a big deal for a lot of us right now. The governor announced some of her ideas around helping get Michiganders back to work. And she specifically announced that she's going to call on the legislature to expand the state's work share program to allow employers to apply who are seeking new staff. And currently, about 1% of all employers use the work share program because it doesn't necessarily help a lot of employers as it currently functions. So the work share program, if you don't know, allows an employer to reduce employee wages and hours so that an employer can retain staff or help restart their business. Those lost wages or hours are then covered by matching unemployment funds, essentially making the worker whole. And additionally, until September 4th, the employee also receives a $300 additional payment from the federal government for this program. So what the governor is trying to do is, by adding new staff to this work share program, which the legislature has to approve because it's written into legislation, is tie the $300 unemployment to a new hired worker until September 4th. That's all she said about it. There's no more specifics. and we have yet to see where this goes. An idea like this was floated in the legislature early on. The business community across the board, advocates have been asking for them to do something about this because the business community is just getting walloped in terms of staffing, and I know we all are as well. So this is an interesting change from the governor's last position where she said she's not going to touch the unemployment at all. So some positive news for workforce on the horizon here. Lastly, I wanted to highlight a unique opportunity for healthcare workers here. MDHHS reached out to us, I want to say a couple days ago, asking for our help in recruiting for 2 one-hour virtual work groups on June 24th. We actually have a date now. These work groups are to discuss why unvaccinated caregivers, direct caregivers, chose to remain unvaccinated. The department's goal is to increase vaccination amongst long-term care direct care staff by 45%. So they're looking to double it to a total of 90%. They are looking for a very wide array of individuals, and anyone in any healthcare setting can apply as long as they're a direct care worker. I listed the criteria they gave me here. They're looking for a diverse group of individuals, preferably between the ages of 18 and 35, from any region of the state, any background, and specifically any provider is eligible. So please forward the message along. And for participating in these work groups, the individual will receive $75 for 1 hour for the 1 hour work group. I have here that we'll be distributing a flyer shortly for this, and to contact me. You can still contact me if you're interested, but they actually got me the final flyer about half an hour ago. So we were able to post that in the handouts. It's called Long-Term Care Recruitment Poster version 3. Please go ahead, and if you're interested, email the email there and help us distribute this amongst direct care staff. I think it's a good opportunity to get them a little bit more money and also help the state learn about why workers are choosing to remain unvaccinated.
All right, thank you very much, Dalton. I am not seeing any questions right now, so we will actually, at this point, we will now turn it over to David Herbal, our president and CEO here at Leading Age Michigan, to discuss our upcoming annual conference.
Thank you, Blake, and good morning, everybody. I hope you're all doing well. Enjoying some of the cooler weather in Michigan that we're having these days. Certainly is a great summer thus far. Today, it's my pleasure to talk to you about our upcoming annual conference and our general theme of hometown heroes, and how we want to be celebrating our hometown heroes, but also celebrating the chance to get back together again in person, face to face in September of this year in Grand Rapids. So today I've got a few announcements related to our conference. Go ahead, Blake, you can advance the slide. This year's conference, we have a tremendous faculty that's rounding out. We've got 2 keynote speakers already on the books for us. It's Pastor Coy Boyer. He's a pastor at Kingdom of Life Church in Lansing. Very interesting individual as I've gotten to know him. He was living in Dallas, Texas for a long time, but then came back to Lansing because this is where his heart is, where his mission is. And there's just a lot of great information and talking with him, and we're going to have him as one of our keynotes. And then also, we're very fortunate to have Lila Lazarus, who's going to be joining us. Many of you who live in the southeastern Detroit area of Michigan probably know her from her work with Channel 7 down there. So we're very excited about that. And then we're also thrilled in terms of content to talk about some of the proposed tracks. We've had 20 submissions from our members, business partners, and others in relation to topics that will be presented at our conference in Grand Rapids. And some of those are listed there on the right of the slide. The general categories that we're looking at are certainly issues in aging, clinical and operational challenges, workforce is just essential for us these days, and strategy and innovation. So we're very excited about this. We've already had 20 submissions, so we're thrilled about that. Go ahead, Blake. And just wanted to mention to you some of the other details about the conference. Registration is going to open today at noon. We're very thrilled about that. So you'll be able to book your room now or become a sponsor, and certainly tell your business partners that our Solutions Expo will be available for them today afternoon, and people can start the registration process very early. We're very excited about this conference being face-to-face with everyone again. We're going to have certainly our gala, our fun night on Monday night. We've got a pack outing scheduled, but we're also in downtown Grand Rapids in the middle of Art Prize, and we're very excited about that. Certainly that creates tremendous opportunities for everyone who enjoys art, but also likes to get out and move around in a crowd. So Art Prize is really something we're looking forward to. And thanks to the Leading Age Michigan team, who negotiated a tremendous rate for us at the Amway Grand of $169 a night. So we're expecting a huge turnout. Love to see you there, and the opportunity to again connect with your peers will be wonderful. A couple other announcements that I wanted to make relate to the awards for our gala. We've had 40 submissions already this year of people who'd like to put forward an application for one of our award categories. But there are two categories that we have yet to receive submissions on. And I'd like to encourage you, if you've not already submitted someone for an award, to think about anyone within your sphere of influence that might qualify for Volunteer of the Year or Trustee of the Year. And those are the two categories in which we're still looking for applications. And I would just, I'd like to mention that, when you're thinking of Volunteer of the Year or Trustee of the Year, I know we kind of label it as an annual award, but maybe this year with the pandemic, we might want to extend the focus of how we look at that. So if you've got a volunteer who's, certainly been in your corner for a number of years, or just someone you'd like to acknowledge, why don't you consider those folks as well as we move forward in this process? So again, those two categories, and we'd love to get a few more applications from you in that regard. You can certainly send those to anisa@leadingagemi.org. If you're looking to register today, all you have to do is go to our website and click on the annual conference banner, and it'll take you right to the registration material for either sponsorship or for an exhibitor, or to register for your hotel room. If there are any business members or business partners on the line right now who want to learn more about the Solutions Expo, please feel free to connect with Blake at leadingagemi.org. He'll be happy to talk to you about our upcoming conference. And certainly our Solutions Expo will be at the DeVos Center, and a tremendous opportunity there as well. So all in all, we're really excited about getting this program kicked off. We've got all the registration and the materials open well in advance. And so we're hopeful we're going to have the opportunity to see everybody and be together again. We're really looking forward to that. So with that, Blake, that concludes my comments, and thank you for the time today in the Safe and Calm presentation.
All right, thank you very much for that, Dave. I also did just want to follow up on a couple things that he did mention, so I can show you guys a little bit. So I will just pull up our website here really quick. As you go to our website, as you load on, you will see this banner here that Dave mentioned. So you can go ahead and click on that, and that will take you to our conference landing page where he mentioned we will have conference registration, exhibitor, hotel reservation, and sponsorship information. So any of that stuff that you need, you can feel free. So hotel reservation, we can click on that, and it will give you just a little brief thing, and you can either call this number directly, or you can go ahead and click on this link, and it will take you directly to make our reservation. So that will be a very simple process. And then another thing I just wanted to follow up on, if you are interested in submitting awards, I just added this today to make it easier for people. So if you go to our website, this events tab right here, you will see something under conferences. Oh, of course, it's not going to show up right now. It was just there a second ago. For some reason, it's not showing up right now, so I'm sorry about that, but there will be another little selection right here, right next to 2021 annual conference, and it says member awards nominations, and so you'll be able to click on that, and it will take you directly to that page. Oh, and there we go. It is fixed. It's on there for some reason now. So yeah, if you are interested in it, you should be able to just go to events, conferences, and 2020 member or 2021 member awards nominations, and it will take you directly to the survey that you need to fill out. Other than that, I think that is everything that I wanted to cover. So we can go ahead and move forward to Deanna's section.
Thank you, Blake, and thank you, Dave, Dalton. We're going to move on and take a quick look at our Michigan caseload and data summary. We'll move fairly quickly through these slides. As of Monday, you can see that we continue to have declines in the 7-day average of new cases here in Michigan. We're finally approaching the low level of caseload that we experienced 1 year ago in June. So hopefully that trend will only continue. In terms of deaths, the numbers continue to decline, but not quite so smoothly. We're in a period of improving numbers, but they go up and down much more, partly because they're batched in groups when reported. The change in county positivity rates over the past 2 weeks has really been impressive. Currently, there are no counties in the red zone in Michigan, and the overwhelming majority of counties are in the green zone, which means that the transmission rates are less than 5%, according to CMS. So I actually thought that conditions being so much better, we would move to a lower level of transmission as CDC defines it. Some of the requirements that we're going to talk about in a little bit, in particular the use of face shields, are based on whether or not a county is in a no to minimum transmission rate zone, or if they're having moderate to substantial transmission rates. So we thought it would be a good time to look up the current CDC list of transmission rates and for counties in Michigan, and they were last updated on June 11. So only the blue counties are in the low category, and most of the state is still listed as yellow, which is moderate. So I'm not sure why that is, since so many of us are in the green county. Most of our counties are green right now. But technically it has some bearing on what you can do, and we're going to talk about that a little bit later. The link for the CDC transmission levels are here on the slide. The long-term care caseloads continue to be very low. They're declining as well. This is the nursing home caseload graphic. You can see the numbers are really minimal. The same is true for HFAs. The same is true for AFCs. And when we look at the data reported by MDHHS as of Monday, the numbers are, the caseload numbers are very low. And staff numbers are also coming down to some pretty low numbers, which is a very good sign. We do see, however, a few resident deaths from COVID are still occurring. In terms of vaccinations, Michigan is currently at 60.5% of persons age 16 and older that have gotten at least one dose. Currently, there are over 4 million Michigan residents who are now fully vaccinated, and that accounts for about 49.6, or really almost 50% of all persons when you look at everyone age 12 and older. So today we're going to take a close look at the current rules for personal protective equipment, along with the OSHA rules, which were just announced last week. They haven't been formally published yet, but they have been announced. And of course, we have a few reporting updates for nursing homes. So we'll start with personal protective equipment. We added this topic today for a little bit more of a detailed review because we continue to get questions on what the current rules are. And as with almost any rule discussion these days, we start with the QSO, which seems to be the basis for almost all regulatory guidance for nursing homes right now, and other settings actually here in Michigan. This policy memo refers to PPE twice, but only within the core principles. First, there must be appropriate staff use of personal protective equipment. And that provision has a direct link to the CDC page, and it's listed here on the slide. Basically, that link provides detailed information about PPE in general with instructions on proper care and use. And that's just pretty much there as a reminder because we continue to see a lot of citations, excuse me, in nursing homes for the proper use or improper use of PPE in handling the PPE. The second provision is about the need for face coverings and social distancing at least 6 feet apart between persons. And again, it directly references a specific CDC guidance for the rules about that, and that link is also here on the slide. So this second link that we just referred to sends us to the CDC infection prevention and control recommendations that have been updated to address vaccination status. They note in general that the use of PPE by staff remain overall unchanged. The recommendations also link to the current infection prevention and control guidance, and that is here also on the slide. And that was last updated on February 23. So those rules, basic infection control rules, have not changed. Visitors must still wear masks in general. So when they come into the facility, when they're in common areas, when they're visiting, unless they meet one of the exception criteria, visitors must still wear masks. Staff should wear well-fitted source control at all times when in patient care areas. They may extend the use of masks and respirators for source control if needed. And of course, there's a big focus on ensuring appropriate fit of face coverings and respirators. That's another thing that surveyors are looking at. The same guidance goes on to discuss standard procedures in areas with moderate to substantial transmission. Everyone, of course, must follow standard precautions when COVID is not suspected. And of course, when it is confirmed or suspected, staff must wear full PPE and follow transmission-based precautions. N95s are still required for all transmission-based precautions and any aerosol-generating procedures. Staff can wear non-approved respirators, but only for source control, or they can wear a well-fitting medical grade or surgical face mask. Someone asked recently if staff could go to cloth masks now that the transmission rates are so low, but there's no guidance that says that. And in fact, the OSHA guidance speaks specifically to the need to use medical grade or surgical masks. The gray area here is going to be eye protection. We have heard that many facilities are no longer wearing eye shields for general care, and surveyors do not seem to be requiring it for basic care. However, the CDC technically recommends them for areas of moderate to substantial transmission. And as a surprise, when I looked at the data yesterday, we noted that most of Michigan still seems to be in that CDC category, although we're green using the CMS positivity rates. So this is a gray area. I think that facilities are going to have to look at that and decide what they really need to do. Of course, you need to use ice shields for any COVID-related care. I'm kind of hoping that the transmission levels will continue to fall and this won't be an issue in the future once we get out of that moderate to substantial CDC category. When there is no transmission or minimal community transmission, obviously you still have to use transmission-based precautions for COVID-related care and standard precautions for all other care. CDC says in this category, you may include the use of eye protection, but you don't have to. And again, as noted in the CDC graphic on the left that we pulled up yesterday, in general, Michigan continues to be at a moderate transmission level. And last week, we asked MDHHS about eye protection, and they simply restated the CDC rules that we just reviewed. The MDHHS response, though, I'm sorry, the guidance, the CDC guidance, forgive me, I got lost for a moment. The CDC guidance goes on to discuss care of persons in isolation and quarantine. There's really no changes there. Technically, there are allowances for optimizing PPE, but most consider PPE in good supply right now. So any contingent or crisis strategies are generally not considered necessary, and you'd really have to support use of those to a surveyor. And of course, there's a lot of emphasis in this guidance on the proper use, donning, doffing, hand hygiene for all types of PPE. And again, we know that a lot of the infection control citations in nursing homes continue to be about those things. So because we were talking about PPE this morning, we wanted to repeat some of the recent guidance from the FDA. Again, they have come out and directly stated that crisis strategies are considered unnecessary at this point. Everyone should be using PPE, especially respirators, based on conventional practice. The FDA site has been updated to include all approved respirators, and you must use an approved respirator for COVID-related care. You can use unapproved respirators for source control if you need to. And any respirators that have been used under extended use, have been decontaminated, those should be disposed of by this point. And here are two CDC resources about PPE. So this is part of MDHS's response about the eye protection piece. The first part, they simply restated all of the CDC rules that we went through. But they also added a comment about using eye protection only as an option during patient encounters. They didn't really say COVID-related only encounters, but patient encounters. Perhaps rather than for all staff that are in resident care areas. But this didn't seem to me really what the CDC was talking about when it discussed eye protection and the need for anything beyond COVID-related care when you're in an area of moderate to high transmission. So it seems to me that facilities are going to have to consider whether to use them for other care. But the focus here from MDHHS was on proper care and use of the equipment. So basically, they're suggesting that you use the county transmission level, availability of equipment, some other considerations. And they note that extended use of single-use shields can be done, but is not considered a best practice. But as far as we know, the surveyors don't seem to be expecting you to wear, for all staff who are not taking care of COVID patients, to be wearing shields at this point. Again, a gray area based on all of the different regulatory sources, but that does seem to be the reality. So any questions about any of that?
It looks like we just have one question, so I'll just go right into that. Why would we have to refer to CDC as well as CMS county positivity maps? This is new to us. Does MDHHS say we have to use the CDC map? I don't remember using CDC maps before now. Do you expect CMS and CDC maps might someday be in alignment?
To be honest with you, I don't ever expect anything to be in alignment anymore after the last 15 months. I'm sorry for that. I think that based on previous discussions with MDHHS, there are certain areas that the CDC guidance relies on as support for their guidance, which is required by CMS. So when you look at defining what is a moderate to substantial level of transmission based on the CDC guidance, I do remember hearing from MDHHS a while back that there is an expectation that you use that. However, I also think that, I don't know how to explain this, but some of the requirements erode over time. They don't keep up with what's really happening. And the surveyors are not even expecting that. So I just want to make sure you're aware of the resources and what the CDC is saying. MDHHS also did refer in their response to us, and I did not include that on the slide, perhaps I should have. They referred directly to that CDC map of county transmission levels. So there is that expectation out there, but in reality, I think most are considering it unnecessary for anything but COVID-related care, and the surveyors are not expecting it. So I'm sorry not to have a better answer for you, but that's everything I know about it so far.
Okay, it looks like that was the only question, so we can go ahead and move forward.
Okay. So we're going to do hopefully a fairly quick review of the updated OSHA rules announced this week. I have included a lot of detail in the slides just for reference. We're not going to go through each provision one by one, but you can use that to refer to later if you need to, the slides themselves. So the actual OSHA rules are over 900 pages long, but thank goodness they isolated the summary for healthcare, and it's a little bit over 40 pages. It's section U, and the link to that is right there on the page. Again, these rules have been announced but not yet published in the Federal Register, and it's only at that point of publishing that the clock starts for implementation. A lot of the rules are unchanged. These requirements apply to all healthcare settings, but not ambulatory settings where patients are screened before entering, not in home health settings where all employees are vaccinated. The state can still apply more restrictive guidance as needed, and employers are still encouraged to apply any CDC guidance beyond that that's required by OSHA. The link to the resources and fact sheets is here at the bottom of the page. So we'll review the major provisions. Note that there are a lot of definitions that precede this section about the COVID plan. I did not put those in, but it would be important to review that when looking at implementation. First, all facilities still need to have a COVID plan. And there are resources on the OSHA website if you need help in creating one. Employers who have 10 or fewer employees must have a plan, but it doesn't have to be written down anywhere, which actually didn't make a whole lot of sense to me, but that's the rule. Everyone must designate a safety coordinator. That's not new, but that person must be identified by name within the plan itself. And that person must also have enough authority to ensure compliance with all aspects of the plan. Also not new is the requirement for a workplace-specific assessment to identify any hazards. And all of those hazards have to be addressed in the plan. Also, if an employer is allowing different practices for persons who are vaccinated. So some persons who are vaccinated are exempt from some of the requirements. That plan must include any policies and procedures related to that. Another piece is that employers must seek the input and involvement of non-managerial employees in the hazard assessment and the plan development. And of course, any of these plans have to be updated as needed. The plan must work to minimize risk of transmission for employees based on the risks that they experience. So you don't have to identify the plan for each individual employee, but you can group jobs by risk levels and address it that way. You do have to communicate the plan to all employees. If you have persons in your building who work for other employees, such as maybe hospice staff, you have to coordinate and communicate with their employer, especially about how you're going to notify any exposures, etc. If employees have to go into a private residence, this could mean for us a home avail for therapy or home health care. There has to be procedures for staff to withdraw from a location if protections are not considered adequate when they get there. For any facility providing direct care, everyone must continue to limit points of entry, screen and triage everyone coming in and out of the building, and basically follow the CDC infection control guidance. Employers must have policies for standard and transmission-based precautions. That's certainly not new. There are 3 sections of the rule that have an exception for fully vaccinated employees. When we review those exceptions, we have to remember that OSHA guidance is all about protecting the employee and pretty much does not have any direct bearing on protecting the resident. So there are a couple areas where CMS is going to disagree about requirements when it comes to nursing homes. So Section F, use of PPE. According to OSHA, does not apply to fully vaccinated staff as long as there's no reasonable expectation that anyone with COVID or suspected to have COVID will be present. Other than that, in general, staff must continue to use masks when indoors and when in vehicles with other people. They must change their mask daily and when appropriate for resident care. Face masks are not required for staff when someone is alone in a room, is eating, as long as they're physically distanced. They're not required when someone must see your face and mouth, such as when you're communicating with a deaf person. And certainly they're not required when they're contraindicated. Employers must provide a full set of appropriate PPE for any COVID-related care. You can follow optimization strategies if needed, that's in the guidance, but remember from the FDA, most are considered unneeded right now. You have to provide a respirator, an approved respirator, for any aerosol generating procedures. Section H is also not required for staff who are fully vaccinated when there's no reasonable expectation that you're going to come up against anyone with suspected or confirmed COVID. And Section H has to do with physical distancing. Employers are expected to look generally how to address perhaps crowded areas of employees, and there are some suggestions here for staggering work and other activities to eliminate close quarters when possible. Section I, also not applying to vaccinated persons in the same way as noted above. If there's 6 feet physical distancing is not possible, the facility must have some barriers. But of course, that's not needed in direct patient areas. But places like maybe your office receptionist, things like that, you have to have barriers if 6 feet physical distancing is not possible. But it's important to remember that QSO 2039 still links directly to the CDC guidance that says that if all employees in a meeting or break room are fully vaccinated, masks and physical distancing are not needed. But if there is anyone present who is not fully vaccinated, all must use source control and unvaccinated persons must distance themselves. So this has been, a rather straight and clear rule since the CDC updated its guidance for vaccinated persons. This is what we've relied on to think about residents. So all of the guidance is absolutely unclear about, well, at least not direct, there's no direct statements that say if an unvaccinated staff person is in a room with residents, that all must mask and use source control. But if you have to have those protections for other staff, it made sense to us that they implied that you have to have those protections for residents. And there's been a lot of questions about this because it is a problematic and hard to follow regulation if every time an unvaccinated staff person, even though masked, enters a dining area, then we have a problem even if all the residents are vaccinated, if they all have to do that. So we're going to talk a little bit about the updated MDHHS guidance that came out yesterday, a little bit later. And that guidance pretty much says that it's not specifically stated anywhere, therefore the facility can rely on their own policies, procedures, and judgments about what to do. So it appears that although QSL refers to this guidance that says if your staff are together and any one of them are not vaccinated, all must use source control and vaccinated persons must distance themselves, that's not necessarily true anymore for residents. But again, you can use your judgment about that to some degree. OSHA has cleaning and disinfection provisions. There's little here that's really new, and it references the CDC guidance. There's the same with ventilation issues. Again, goes back to the CDC ventilation guidance. So I don't think there's really anything new here much. Again, the requirements for health screening and medical management have not changed. Notification requirements have not changed. You do need to note that these notification requirements are only about notifying other employees. There are obviously more notification requirements than that for MDHHS and nursing homes and long-term care facilities. And of course, whenever you have an employee who is caring for perhaps a new COVID resident, but using appropriate PPE. Any contact with those patients is not considered a close contact as long as all of the precautions have been taken. So no notifications are required for that beyond those that are needed by MDHHS and CMS. There is a section on the need to remove someone from the workplace based on suspected or confirmed COVID. Obviously, you must immediately remove those persons, and they cannot return until meeting the criteria, or if only suspected to have COVID, they can return if the PCR test is negative. Remember that MDHHS has additional rules for that. The quarantine time for close contacts is a bit different. We suggest, again, you use CMS and CDC guidance. And if an employee is fully vaccinated, they don't have to be quarantined following close contact. The important piece here is that if someone is medically removed and working remotely, so they perhaps are not ill, but they're positive, all pay and benefits must remain the same if they're working from home, simply because they might be contagious. If they have been removed and they're not working, employers must continue to provide benefits and pay up to $1,400 per week until they can return to work. There are different rules for employers under 500 employees, but only if that period goes beyond 2 weeks. And of course, pay can be reduced if the employee is getting other compensation. And on return, there of course can be no adverse actions against the employee because of a COVID-related leave. Decisions to return to work must be in alignment with CDC guidance. Employers must support employee vaccination by allowing time to be off for administration, time to resolve any subsequent side effects. There's a large section on training requirements for all staff. There's a long list of topics, kind of small to see, but I did list them all there. And training of all staff is required. Additional training is required whenever the risk levels for an employee change, or policies or procedures change, or something's not working, employees are not complying for one reason or another. And of course, all of those training episodes must be documented. And training has to be overseen by someone who is knowledgeable in the subject area, and training has to be interactive. It must allow for discussion and Q&A, etc. Employees also have to be informed of their rights, and they cannot be discharged for exercising their rights or engaging in any actions required by applying these provisions. In other words, if they're applying a provision of the rules, you cannot fire them for that. And that also includes their right to file any complaints. And of course, all these requirements must be implemented without any cost to employees. Facilities with more than 10 employees have to keep a record of every COVID plan and every update. So every version of your COVID plan has to be kept as long as the order remains in effect. You also must maintain a log that records every employee who's COVID positive, regardless of whether it was contracted related to a work exposure or not. The rule lists what has to be included in the log, and any entries have to be made within 24 hours of identification of that person. On request, so if an employee requests, you have to provide any and all versions of the COVID plan to them. You have to provide on request an individual log entry for a particular employee to that employee only. And you must keep and provide a de-identified log that is available on request. You have to provide it to any employee, any resident, or any representative. And based on their requests, for any of these things, you have to provide those within 1 business day. You must report any work-related COVID fatality to OSHA within 8 hours of identification, and any work-related COVID hospitalization within 24 hours. And of course, there's the normal general reporting requirements. In terms of implementing these provisions, you have 14 days, excuse me, following publishing in the Federal Register, except for 3 sections. I think it's I, K, and N. Yes, I, K, and N. You have 30 days from publishing to complete those. And lastly, the guidance also has a section called Mini Respirator Program, and that is several pages long. It identifies the requirements for respirators and training and use of respirators, etc. So there are some requirements about that you might want to review as well. So that completes the OSHA review. As you all must be aware, we've been communicating with MDHHS for the past 15 months on many, many topics. Not the least of which is trying to figure out what their expectations are for the actual requirements, and sometimes about the conflicts between their requirements and the CDC and CMS guidance. We have had governor executive orders, which have now been rescinded, pretty much replaced by MDHHS epidemic orders. And in addition to those epidemic orders, there have been, since almost the beginning, materials that have also been published and placed on their website. And many of those materials over time have been difficult to interpret, and they've conflicted with other guidance. So some of those materials are process related, such as how to get reimbursed for testing, who you have to test, things like that. And those are obviously meaningful and necessary. There were 3 that have been particularly problematic for us. I have listed 2 here, since the first one has finally been taken down from the MDHH site. That guidance was the one, I forget the name of it, that pretty much said that all settings had to use all PPE for all care. So they've finally gotten rid of that, which we considered arduous and burdensome. And for a long time, no one was really applying it. The 4.2 guidance that we listed here, it's still out there. And it's the one that includes independent living in the quarantine requirements based on vaccination status. When that came out, we asked the department about that immediately, and we really never got a good response about that. But we did get a response this week. And we have had some serious, detailed conversations with the state about trying to figure out what the expectations are. So except for the inclusion of independent living in that guidance for quarantine, which seemed impossible to us, it does pretty much follow the QSO requirements. It just seems like it was inappropriate completely for independent living. The second document that I've linked here is the guidance that speaks to visitation, and it was last updated yesterday. This was first issued right after the updated visitation guidance was done by CMS. And we found that some of those pieces conflicted with the QSO. And MDHHS came out and said at that time that it was a best practice document only. So yesterday they updated it with the statement here. And I think this is an important statement, and I think that it does come as a result of our strong advocacy, trying to figure out how to negotiate and mediate all of these different guidances. So for scenarios that are not explicitly expressed in either the MDHH order or the CMS QSO, facilities have the ability to consider their own circumstances and infection prevention and control protocol to inform their operations. So to me, what that's saying is that if it's not an epidemic order and it's not related to the CMS or CDC orders that they refer to, that you can use your judgment. In addition, in that new piece, they included some FAQs. And the FAQs, a lot of them, as I reviewed them last night, seemed self-evident. A couple of them, I think, could have had a better answer, had some nuances to it. So we're going to go ahead and review those and incorporate them in a revised Q&A that we will send out, hopefully later today or tomorrow morning, depending on the time needed to do that. We're going to review a few of these FAQs, but I think some require a little bit more thinking. So go to the next slide, Blake, and we'll go through some of the pieces. So obviously, the FAQs, again, point to QSO 2039, and that means the core principles, but remember that facilities can use discretion for scenarios that don't 100% align with the CMS guidance, and also for scenarios that CMS says, you know, you can consider these issues also when you think about visitation. But you're not allowed to deny visitation unless you confer with your local health department. Facilities can use the MySafe Start or CMS rates when you're thinking about visitation. And remember, this is not about those shield issues that we were talking about earlier. This is about visitation. Nursing homes must use CMS positivity rates. But remember also, in terms of testing, the state has a bottom level requirement for all vaccinated staff to be tested weekly still. You must allow visitation as indicated by the QSO and directed, unless directed otherwise by the local health department. Compassionate care is always allowed. It does say that you do need a licensed healthcare professional determination to identify the need for compassionate care. If unvaccinated residents are present, all must maintain 6 feet distancing and mask. Now that is actually in the epidemic order. They don't want to isolate unvaccinated persons more than the vaccinated persons if they're all together in the dining room. So that is, different from the CMS guidance, but they have it specific in the epidemic order. They did write this a little bit differently, which is why I have the question mark there. I think that they say that differently than is written here, but not in any great way. Presence of unvaccinated staff. This is the part where they said it's pretty much at the facility discretion, or at least that's my interpretation of their response. Although again, it doesn't make sense if you have to, if there's any unvaccinated staff, when there's only staff, you've got to mask and socially distance, but if there's residents available, you don't have to, but that's what the department's saying. Can fully vaccinated staff who are in positions that do not involve direct resident contact remove their mask? And pretty much they said, no, the guidelines apply to all. But I think that there's more here because there are times that fully vaccinated staff can remove their masks and the rules apply to them. But just because someone has a job that is never coming into direct contact with residents doesn't mean that they have different rules than everybody else. But again, we're going to go through these FAQs and integrate them into our Q&A document and get that out to you hopefully within the next day. We have a few final notes. There is a new ARC tool for nursing homes to audit the appropriate use of PPE. There's also a user guide. This supposedly would help you in your CAPI efforts. I did not review the tool itself, but it is something that's available to you. Provider relief reporting, I think at this point, it's been several days since this new guidance came out. The new requirements updates the guidelines, the deadlines, it staggers the reporting requirements. There are links here to the leading age review of the revised requirements and the new reporting schedule for your review. For nursing homes, we want to remind them that MDHHS will be conducting an audit of data submitted to EM Resource compared to NHSN reporting. The link to the requirements are here, and the first phase started on Monday. That's the review of NHSN data, and there is an opportunity for members to correct any inaccuracies. So please review the guidelines and your data. You have until July 12 to get that completed. So look at that closely because you can fix your data. The second phase has not been scheduled yet, but will include a review of the MDHHS data and EM Resource. And of course, the links are here. There are 5 elements for that data audit that you need to be looking at, and there are only these 5, so this is what you should be reviewing. Yesterday, MDHHS also updated the requirements for reporting. They can submit information on resident therapeutics through to NHSN for facilities that are using that communication mechanism. They cannot, however, transfer data about vaccinations. So members are going to have to do that directly to NHSN. The instructions have been updated and they are linked here. We're still waiting for the final announcement that compliance for vaccination reporting is going to be delayed until this weekend, although CMS directly told Leading Age that they are delaying it. We have added resources for to assist any members who might need some help in reporting. And also CMS has published a list of facilities who have not yet reported, estimated to be about 2,500 facilities. However, we're also hearing that the list is not very accurate, and we're kind of waiting for any further updates from CMS. And that ends our webinar today. So do we have any final questions, Blake?
All right, thank you very much, Deanna. We do have a few questions, so I will just hop right into those. Does the OSHA standards replace the MyOSHA workplace requirements?
Yes and no. The state has the ability to make more restrictive requirements. So it's kind of like, think about it like you would CMS if you're a nursing home. The basic requirements come from OSHA. If MyOSHA requirements are more restrictive, you have to go with those.
Okay. Is there a template that can be used to write a COVID plan?
Yes, I believe there's a template. There's at least, I don't know if it's actually a template, but there are guidance documents on the OSHA website. If for some reason you have a MyOSHA survey, you're going to have that plan. So I would suggest, if you're not 100% familiar with that or not comfortable with what you have so far, that you go to the OSHA, just go to the general OSHA website. I think that the link to the guidance also links to those resources.
Do vaccinated staff need to be tested weekly?
No, just unvaccinated staff.
Do we have a list, or can we have a list of all members who mandate vaccination of staff and or residents?
We don't have a list. We can certainly talk about that and see what we can do to get it. I'm not, to be honest with you, I'm not sure that, I don't personally know of any of our members that are doing that, but there may well be, and we can look into that.
All right, it looks like that is the last question. So if you do think of anything after this webinar has concluded, as always, you can reach out to the Safe and Calm, David, Dalton, or Deanna at leadingagemi.org, and we'll make sure to get any questions answered that you may have. So with that, we would just like to thank Deanna, we would like to thank Dalton, and thank Dave for joining us today as well. And we would also like to thank the 80 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. As always, our next webinar will be scheduled for 2 weeks from now. So I believe that will be the last day of the month, Wednesday, June 30th at 10 a.m. We will see you all then. I hope everyone has a great remainder of their Wednesday, and make sure to check out that annual conference webpage. Thank you and have a great day.
Have a good day, everyone.
Take care.